Hi, good afternoon, and welcome to the Epilepsy Foundation of Connecticut, our January webinar, which is titled, What's New in Epilepsy Surgery? This is Monica Anzalone, and I'll be moderating today's webinar. For the purposes of sound quality, all participants have been put in listen-only mode. However, we do welcome you to use that little chat icon located at the bottom of your screen, and you can type your questions there, which will be answered at the end of the presentation. Today, we will be joined by two doctors from the Yale School of Medicine who will be discussing deep brain stimulation, or DBS, the latest neurostimulation device approved by the FDA for patients with medication refractory epilepsy. Today's discussion will include evidence behind the utilization of DBS in medication refractory epilepsy. I would now like to introduce our presenters. Dr. Jason Gerrard is an assistant professor of neurosurgery specializing in epilepsy surgery as well as functional neurosurgery. He is the chief of the functional and stereotactic and neurotrauma sections of the Yale School of Medicine, Department of Neurosurgery. He's also a member of the Yale Comprehensive Epilepsy Program as part of the epilepsy surgery team. Dr. Gerrard has been called into surgery at this time, so he may or may not be joining us. However, we do have Dr. Aline Herlopian, who is an attending epileptologist at Yale Hospital and an assistant professor of neurology at Yale University. Dr. Herlopian's clinical interests include, but is not limited to, medication refractory epilepsy, epilepsy surgical evaluation, as well as neurostimulation. So I would now like to hand it over to Dr. Herlopian.
Thank you, Monica. Hello, everyone. Today we're going to discuss about what's the latest update in epilepsy surgery. The objectives of this presentation is, first of all, we're going to discuss what the indications are for the deep brain stimulation implantation, which we're going to talk in detail about, its mechanism of action, how do we implant it, what is the evidence behind this use, what are the side effects, and what can we conclude from the entire presentation. So as an introduction, the DBS, which stands for Deep Brain Stimulation, has been introduced in France in the 1980s. Initially, it was approved by the FDA for tremor treatment, Parkinson's disease, obsessive compulsive disorder, and certain other movement disorders. However, given its great efficacy in these diseases, they started to explore it further as a treatment option in various other conditions, and one of them, which is our interest, is epilepsy. So just in a nutshell, to just go over how the device looks like. So basically, this is the main battery of the device, includes, so this will be implanted in the chest, and this is the wiring, and this wiring goes straight to the brain, and that's how it's going to be implanted. As you see here, this is a different device type, which we're not discussing today, but I just placed it for comparison. And this is the deep brain stimulation, which we're going to talk in detail about. So as you see, the wire is taken up and goes in underneath the skin. So there's nothing that shows up on the skin. It's all underneath. It goes up and underneath the skin, and it's placed in the deep part of the brain. So there's not going to be a scar in the brain as this other device, which we use it to implant it on the brain. So what are the indications of DBS, when we should think about it? So 30% of people who have epilepsy fail medication. So no matter how much medication we give them, their seizure is still ongoing, persists, they have side effects from medications, and their quality of life is impaired. For those patient population, what our aim is to provide them with an investigation process, which is called the pre-surgical investigation. And we try to see in those patient population if surgery is an option or not. And when we say surgery, we mean resection, which means cutting a part of the brain that's causing the seizure without having any further neurological impact in the future after the resection, and with our aim being excellent seizure outcome. Certain cases when we perform this investigation process, which includes people coming to the hospital, monitoring their seizures, doing MRI to see if there's any abnormality on the brain, when we find out that these patients, or an X group of patients, are not surgery candidates, either because we cannot perform surgery because the seizures come from the part of the brain that is very vital for major functions, for example, hand movement or memory. In those patients, we decide to utilize devices so that we can prevent and help control with the seizures. On the market currently, we have 3 types of devices. The longest that has been studied and utilized has been the vagal nerve stimulator, which we call it the VNS. The second device that was approved and now we use it is the responsive stimulation. And the latest device that was approved by the FDA for epilepsy is the deep brain stimulation. So this is the latest device that has been approved. It has been utilized in several centers, and we're going to be implanting it outside the research field and for clinical purposes. I would like to note that the DBS has been utilized for many years for Parkinson's and tremor. So the epilepsy is new. However, it has been used for other purposes. So we're going to discuss about the DBS, the deep brain stimulation in epilepsy. So those are certain, I would like to talk about certain examples where we can utilize DBS. As we said, for example, this is our brain. As you see here, this is the brain. We're looking from the left side, and this is the bottom part of the brain. This is our front part where the eyes are located here, and this is the back part of the brain. So sometimes, for example, seizures come from multiple parts of the brain, here and here and here and here. So this might be a challenge to say, okay, if we take out this side, seizures are going to be controlled. Well, that's a challenge. That's why in those situations, sometimes we offer devices because we cannot perform resection. Another example is if, for example, the seizures do come from this part of the brain, which is the language part. We cannot take that part out because if we take it out, the person is going to be unable to speak, unable to find words. So that's a challenge. That's why we do not perform surgery on this part of the brain or this part of the brain where we have the hand motion, and we cannot resect that part of the brain because it might make the hand paralyzed. So those are some of the examples where we can say, well, it is possible time for us to utilize the deep brain stimulation because we are unable to perform resection. We are unable to resect that part of the brain that's causing seizures. So how does the DBS work? So as you see here, the DBS is placed in the chest. It's going to be a small incision, and the wire travels to the brain. You see the tip of it. It has 2 tips, and these 2 tips are inserted into the brain. And the way it works, it delivers impulses, which means it delivers electricity, or we call them stimulation, that the physician sets it and programs it. So when the person goes home, it keeps firing. The DBS does not sense a seizure. And so it does not give impulses or electricity only when you have a seizure. What it does, it keeps stimulating at a certain pace, regardless if there's a seizure or not. And the step that we usually do, again, this is in the chest, this is the wire, it traverses under the skin to the deep brain. So those are the leads in the brain, the extension and the device. What happens is the physician will have such a the programming, we will try to put this device here and program the device to a specific stimulation setting. These stimulations over time can be adjusted, turned up, turned down, make it longer, make it shorter. So it depends on how much we're giving stimulation. And in this way, we will have a programming of the device. So where do we implant? So as you see, this is the brain of the individual and this is his face. So this is the deeper portion of the brain, which we call thalamus. So this is the thalamus. And the device, usually the stimulator, we put the electrodes here into the anterior thalamic nucleus. This is a part of the brain, a specific territory in the brain. This is a center here in the midline. We put it there as well. Or we can implant it in these parts of the brain that's called the hippocampus. So those are the areas of the brain we put the deep electrodes in. This is a picture as well this is an X-ray picture of an individual who has it placed in the hippocampus, as I showed here. As you see here, those are the small electrodes. So they are placed here deep in the brain. And if you see the X-ray, you see how the wires are linked to the device here. So what is the evidence behind the DBS? So basically, DBS has been studied for its anti-seizure effects since 1970s. Monica?
Yes.
With us online? He's with us online, okay?
Yes, he is.
Okay, so the DBS has been studied for its anti-seizure effects since the 1970s. And there have been multiple studies that have looked into the effects of the DBS on seizure count. Does it decrease seizure? Does it make it worse? Does it make it better? And the questions that have been entertained along with its efficacy over years' time is where do we put these stimulators? And those areas of the brain are the three main areas that have been tested are these centers that we call them the anterior thalamic nucleus, the hippocampus, and the centromedian nucleus. So those are the three main centers that have been studied for the seizure effect of the DBS. So as you see here again, that this is another picture to show us where exactly these centers are. So these centers, which we call them the thalamus, are in the deeper part of the brain. So you have to split the brain apart to see these centers. So in these centers, as you see, if you take this out, this part, which we call the anterior nuclei, is in the front portion, and the centromedian is in the deeper portion. So those are the areas where we implant the electrode of the DBS. So for the anterior thalamic nucleus, why do we implant the anterior thalamic nucleus? What does it do to epilepsy? What is the rationale behind it? So basically, when we implant the anterior thalamic nucleus, as you see here, it has a highly dense link to the hippocampus, which is involved in a specific type of epilepsy we call temporal lobe epilepsy, which means it's the type of seizure that comes from this part of the brain called the temporal lobe. So the rationale is, if we keep stimulating the anterior thalamic nucleus, we will stop these seizures that do come from these circuits, and hopefully over the long term, we will have a seizure reduction because the stimulation will help us lower down the seizure frequency or the impulses that are sent originally by the brain to produce a seizure. So what evidence do we have for the anterior thalamic nucleus? So in 2010, they published a landmark study that's called the Sante trial, and they studied 110 adult patients. In the first 3 months of the stimulation, what they have done is they divided patients into 2 groups. A group that receives true stimulation and a group that receives sham, which means the patient does not get any stimulation, but no one knows if they're getting or they're not. That's what the blinded part is. So they followed these patients for 3 months, and they found out that the people who received true stimulation had 40% seizure reduction. This is in comparison to the people who did not receive the stimulation and had 15% seizure reduction. So this is a 3 months follow-up. On a long-term follow-up over 5 years, they found out that people do have 69% seizure reduction rate. And what they did is they wanted to see, is there a specific group that does way better than the other group? Or is there a specific type of epilepsy that is more responsive to DBS of the anterior thalamic nucleus? And they found out that the temporal lobe better, which is 76% in comparison to the 59% of the frontal lobe, which is this part of the brain, or other types of the seizures. Sometimes they do come from here or this part. So this means that when we stimulate this ATN, that's why the temporal lobe epilepsies are getting better, probably, is because of the dense circuit that we have with this part, which is the temporal lobe, and that's why we see a better reduction in the seizure frequency. So the second area that we can implant is the hippocampus. So the hippocampus, as you see, this is the face part. So this is the deep part of the brain. It's again in a deep part. And this is where our hippocampus is. And do you remember these dense connections that we had from the thalamus? So these are linked to the hippocampal area as well. So for the hippocampus, the patients that were studied are less in number in comparison to the ATN. So here we're stimulating the hippocampus directly rather than stimulating the anterior thalamic nucleus. So we have 3 main studies where they compared stimulation to no stimulation. And as you see, the number of the patients, they are low, 4 to 9. And this is in comparison to 110 patients that they have done for the anterior thalamic nucleus. In all these studies, they showed that there is a good seizure reduction between 13 to 40% seizure reductions overall in all these studies. Now, there's one thing that they observed in these 2 studies is that people who had normal MRI and a temporal lobe epilepsy, they did better with the hippocampal stimulation. However, we cannot rely much on said the number of the patients is low. So this is for the hippocampus. And the last one, the nucleus, is the centromedian nucleus. As you see, the centromedian, it's so tiny and it's so deeply located inside the thalamus. And that is in comparison to the anterior nucleus, which is in the front part, or even the hippocampus, which is exposed in the brain better than the centromedian. Now, the studies that have been done in the centromedian, we have 2 studies, and we have actually one controlled study, and in this they had a very low number of patients, again 7. So they studied focal seizure, which means a seizure that comes one particular part of the brain, or generalized epilepsy, which means that you have a seizure that comes from a broader part of the brain. And they found out when they stimulated it versus 80% when they provided sham stimulation, which means that they delivered the stimulation. We can take it as the stimulation was not turned on and there was no electricity that was going to the central median nucleus. Now there's one type of a epilepsy, which we call it Lennox-Gastaut syndrome. And this is a type of an epilepsy where people do have different types of seizures. They have twitches, they have drop attacks, they have convulsions, staring spells, cognitive delays. These type of patients are the ones that did better on stimulating the central median nucleus. And you see the seizure reduction is 81.6% in this group in comparison to focal epilepsy, which comes from a single spot in the brain, which had 57.3%. When they provided the stimulation, they had a better improvement on the EEG. Their spikes have reduced. Again, these are very small numbers, so we cannot give a definitive conclusion on these trials. So what should we anticipate based on what we see from these studies is that so far we have good data, at least on the anterior thalamic nucleus, not as much on the hippocampal side or the central median. However, there seems to be a good data in terms of the seizure reduction, at least from our controlled studies. What should we do in the future? How should we study further? What are the aspects that we need to explore and to improve our patient selection and to provide better response is to see what predicts the good response. Basically, which seizure types they do better on the DBS. Is it the temporal lobe? Is it the frontal lobe? Are they generalized type of epilepsy? People, when they do have abnormal MRI, which means there is a structural lesion, there is some part of the brain that is malformed. Is that part of the brain that they do well on DBS or not? Or even which side of the brain, if we implanted that part, that patient population will do better. So those are the things that we need to explore in the future. Now, what are the side effects? What should we expect from the DBS? So we can divide it into 3 categories. Basically, what we have is threefold. The surgical, immediately within the operative time frame. We have stimulation related, and this is the related. So if we say surgical related, basically what it means, small bleed, infection around the surgery area, pain with the incision side. Stimulation related, for example, could be worsening of seizure at the start or tingling every time they receive stimulation. You might think about, for example, the vagal nerve stimulator. Sometimes people get this unusual voice every time a stimulation is triggered. So it's the same way here as well. Every time a stimulation is triggered, people might get some tingling, headache, cognitive issues, sometimes depression. So those are the things might be related to stimulation. And the device related is the lead can break. The lead sometimes can move around at the site of the implantation, or the equipment itself can get infected. Now, most of the data from the DBS side effects, we got it from the Parkinson patients or the tremor patients, because those are the people who have had the implantation for the longest time. And it seemed that the most common, but as you see, the percentage is very, very low. It's bleeding or the wound infection or even the lead migration. From the epilepsy trials, so what have we learned from epilepsy trials is that usually the most common reported side effect is the tingling, what we call them as paresthesias, or some sensory disturbances, like they're a bit numb, the pain, the implantation site pain, the implantation site infection. Sometimes the hardware in the chest might cause discomfort. The lead can be displaced. There might be a small bleed in the brain, or the infection at the implantation site. Those are the things that have been reported, epilepsy related. However, they have to be explored further over time. And the reason for that is because for Parkinson's, it's a different site of implantation, especially if we're going to do hippocampus or if we're going to do anterior thalamic. So it's a different place where we're implanting. So we probably might see different symptoms that we have not seen or explored earlier. So this is for Dr. Gerrard. Maybe he can take over and discuss a bit further what we see here on the pictures. This is the OR.
Can you hear me, Dr. Herlopian?
Yeah, I can. How are you?
Perfect. I'm great. Thank you. Thanks so much for that great review of the data and used for doing DBS for epilepsy. Just in the last few minutes, just briefly go over the techniques that are used for placing the electrodes. There's a variety of different techniques that can be used. The old standby technique, if you will, is the placement of a frame onto the skull. And then we get imaging, and then this allows us to then target small areas inside the brain with a coordinate system that's based on that frame. There are now also some robotic systems that will help us with the stereotactic guidance of placement of the electrodes. One of the techniques that's newer that's actually very nice for this type of technique is what's called direct image guided placement, and that's what you see on the screen here. This is actually a picture from our MRI operating room where we have an MRI scanner that can come right to the operating room table. And on the left, you can actually see us placing an electrode through a small plastic tower that we can line up exactly on target. So we have our target that's deep in the brain, as Dr. Herlopian's pointed out. And we bring in the MRI scanner, and then we line up that tower directly onto our target, and then we can place a placeholder down to the target. We can then get a full MRI scan to verify that the electrode's going to go right where we want it to go, and then we can place the electrode down to that target. I think you go to the next slide. This is a sort of a pictograph of what this little target can do. It has the ability to move in multiple planes so that you can align properly to the target that you're trying to place the electrodes in the brain. And what it does is it shows like a red line and a yellow line there. It takes your target and it does a scan, and it tells you like how far off from your target you are and which of those colored knobs on the top you need to turn and how much to turn it in order to correct so that you're directly on target. And you do this a few times until you're directly pointed at your target. Next slide.
I think that's, let me just, hold on. Just give me a second. Let me open those up for you for a second. Hold on.
If you don't have those slides, it's fine. I mean, that's the gist of the technique. There are, okay. I think there was one slide with just an MRI scan that shows the electrodes in place as the technique's being utilized. So there's a variety of these procedures that can be utilized. One of the nice things about the MRI, the direct image guided technique, is that you see the images in real time as you put the electrodes in. So it's nice to have that sort of real-time confirmation. It's the bottom two slides. Have that, just go to the bottom two. Yeah, so that's how we do DBS. So this is it. This is the picture of the tower. This is a hippocampal placed electrode, but this is for the idea. And so you see the tower, and you can actually see where our placeholder and our electrode's going to go. exactly where we want it to go. In the picture on the right, you can see that the device is the yellow dot and the target's the red dot, so we can really be very accurate even with a long trajectory pathway. And then I think there's only one more slides, and that is a fusion of a post-op CT scan with that intraoperative MRI scan, and this is just to show that the electrodes really do go exactly where we see they're going to go on the MRI scan. And what's nice about this technique is you see in real time that the electrodes are going exactly where you want them to go.
Okay.
So those are the main techniques that are used for placing the electrodes in place. And then the patients typically go home and come back a few weeks later, and we then connect those electrodes up to the stimulator pack that you see on the previous slides in the chest.
Thank you, Dr. Gerrard. So in conclusion, the most common sites that we now use for implantation of the DBS is the anterior thalamic nucleus and the hippocampus. So this is a nice study by Lee and Cook, where what they've done is they gathered all the studies in the literature, and they found out that on the short term stimulation, there is 40% seizure reduction if you implant the anterior thalamic nucleus, versus the hippocampus is 26 to 40. This is short term. The long term, as you see, the numbers get better. So this means that the DBS is not something that's going to give you an acute or at the moment, at the instance, a great response, but over time, the effect, it is better and it's more efficacious. So as you see on the long-term follow-up, you have 50 to 70% reduction in seizures by the anterior thalamic nucleus implantation, in comparison to 45 to 93% for the hippocampus. Now, 70% of the patients that have either anterior thalamic or the hippocampus, they have more than 50% seizure reduction. And how about the central median nuclei? Basically, those probably are better with people who have Lennox-Gastaut or generalized forms of epilepsies. However, we do not have data that supports these. So those are observation, and they need to be studied further. The DBS is not cure, and it should be considered for palliative purposes, which means our aim should be seizure reduction. And the DBS should not be a substitute for a medication, which means if you want to have the DBS implanted, it should not be in your mind that, okay, I'm having the DBS and I'm stopping my medication. However, over the long term, if the seizures gets better and the seizures are reduced, it is not irrational or not uncommon to consider tapering of medications, and that is based on the response with the DBS. And also, last is to say that if people are not candidate for then we can have them entertain the option of the DBS, and this will help hopefully with seizure reduction, and it will improve their quality of life. I think we're done.
Okay, thank you, Dr. Herlopian and Dr. Gerrard, for that presentation. And if it's okay, can we take just a few minutes for questions?
Sure.
If people that are on the call, if you can type your questions there at the bottom, we can go ahead and read those and get those answered for you.
Dr. Gerrard, you're still there?
I am still here.
Okay. Okay. I can see who's online.
I do have a few questions myself while we're waiting for others.
Okay.
How long does the procedure typically last?
The surgery itself is done typically in 2 surgeries. The first surgery takes a good part of the day, usually about 6 hours to get those electrodes put in. And then the second procedure, which is a few weeks later, is much shorter. It only takes about an hour and a half to get the electrodes connected up to the stimulator pack in the chest. The first surgery is typically an inpatient stay, so patients will stay in the hospital, usually 1 or 2 nights in the hospital. And the second surgery is most often done as outpatient procedure, so the patient gets to go home the same day.
So there is a little bit more recovery time for this procedure than, say, for the vagus nerve stimulator?
There can be, yeah, that's true. There can be a little bit more recovery time, especially with the fact that you have the 2 surgeries that are separated by a couple of weeks.
Okay, and it looks like there's one question here. Can DBS be used along with the VNS?
So that's a good question. I'm interested to see Dr. Herlopian's response as well. They did not exclude patients who had VNS, and I don't believe they forced them to turn them off. Maybe I'm wrong about that. The short answer is we don't have a lot of good data yet, but we're not excluding patients who have VNS from having the procedure done.
Also, the thing is to think about, if you have the DBS and the VNS working at the same time, the question would be, is the DBS alone is working if the VNS did not work, or if combined they work or not? The outcome, which means the follow-up over time, would be sort of confounded by the fact that they're both running or they're both stimulating at the same time. So we don't know yet. We don't have data. We don't have evidence, and we don't exclude them, as Dr. Gerrard say. But over time, over long-term time, with further on the DBS stimulation, the settings, is the DBS fully functioning 100%? Is this the outcome from the DBS only, or the VNS is also doing its job and you now require 2 devices at the same time to reduce the seizure? So those are questions that might come up over the long-term follow-up time.
And are these, I know this really is not a presentation about all of the stimulation devices, but I'm just curious, with the 3 that you mentioned at the beginning, the DBS, the VNS, and then the RNS, do they all pretty much function in the same way? But the procedure is a little different, and the surgery part is a little different. Are they essentially doing the same thing?
So they're a bit different. All of them, they provide stimulation. So, but the way of action is different. For example, to start with the responsive neurostimulation, what basically that is the word also implies it, the responsive. So you place the electrode, or what we call it sometimes strip, on the exact site that the seizures are coming from. So when that strip or the electrode senses a seizure and you make the adjustment over time as you follow up, that detected seizure is given a stimulation. So this is not the same way as the DBS or the VNS works. Now the VNS, you have the electrode placed around a nerve called the vagus nerve, while the DBS, it is deep in the brain. And those are the centers of the brain that are linked with a network, or you might call it as a highway, to the areas of the brain that you assume that the seizures are probably coming from that area. For example, in the anterior thalamic, you say, okay, those are the temporal lobe epilepsies. That's why I'm stimulating the anterior thalamic. So the DBS and the VNS, they fire there's continuous ongoing firing. It is not contingent upon detection of the seizure, unlike the RNS. Now with the DBS, the site of the stimulation is different, and with the VNS, the site of the stimulation is different. Now the question would be, how does that act? What does it do to the brain itself? We don't actually know 100%, but we assume that the those stimulation, it changes the way the brain fires. That's why we call it neuromodulation, which means over long-term time, the efficacy is better. And that's what has been observed in the studies. It's over long-term time, those seizures get better.
Mm. Wow. And certainly then, the doctor would make the correct choice, or what they think would be the correct choice as far as which one would be best for each patient.
Yeah.
Okay. Well, if we don't have any further questions, I guess we can go ahead and, although I do have one more quick question, which is, has this been approved for children, or is there an age range here?
Yeah.
It's right now the FDA approval is for adults, so it's those over the age of 18. The RNS system was also originally approved for adults, and as we've gathered data, it has been utilized in younger patients, and there's been an increasing amount of data that's been collected, and at some point they'll use it to get approval, formal approval in pediatrics. It's technically off-label at this point in time. But I imagine we'll be gathering data on that subject as time goes by.
Well, this is great, and how wonderful to see this additional option for people. Really, very fascinating too.
Yeah.
This has been recorded, so if anybody in the future would like to listen to this recording, you can go to our website, which is epilepsyct.com, under our webinars page, and it will be available there for you. So please share with others. We'll also put it on our Facebook page. And on behalf of the staff at the Epilepsy Foundation of Connecticut, I'd like to thank the presenters today, Dr. Herlopian and Dr. Gerrard, for taking time out of your schedules to share this information with us, and also for all the participants for being on the call today. Thank you as well for your interest in this subject.
Thank you so much. Thanks, Dr. Gerrard.
Yes, you're welcome, and thanks for having me. I appreciate it.
Thank you.